So these patients will often have recurrence after surgery, and the recurrence of endoscopic, I should say, the endoscopic recurrence after surgery predicts what happens long term. So a patient within a first year who is lucky enough or fortunate enough to have no recurrence or minimal recurrence, the rate of progression is pretty low. But then look what happens. If they have more than 5 ulcers, they have a score of a 2, the rate of recurrence goes up. But then alarmingly, if they have a 3 or 4, the rate of recurrence is very high, but also the need for another surgery. So again, why do we see so many patients who are coming in with their 2nd, 3rd, 4th, 5th surgery? It often can be predicted very early. The other very alarming aspect, and I'll prelude this to a slide I'll show later, is the scores of 3 or 4 now are rated to be as high as 60 to 70% 1 year after surgery, especially for the high-risk group of patients, but they're generally clinically asymptomatic. So these horrible-looking photos that I showed you, many times patients do not feel that. They have no clinical symptoms. Why do I think the postoperative course is interesting? And again, let's forget treatment for a minute. But I think that this may give us the first glance of or glimpse of a disease, a chronic disease, where we can essentially reset the clock. Now, I realize that I'm saying this simplistically. It may not be that simplistic, but essentially resect the bad piece, if you will, do an anastomosis, and be able to look at that anastomosis to see what happens going forward. We now know that probably when patients present to us for the first time in the clinic with Crohn's disease, all of us who have seen IBD realize this, probably their disease didn't start a few days ago, probably started 10, 15 years ago, and there's been an accumulation of inflammation, scarring, vascular changes, tissue remodeling that has occurred over a long period of time until they finally present with symptoms. We also know that probably to best and adequately detect disease requires some type of structural evaluation, mucosal inspection. I know Peter in your group here is looking at ultrasound, different ways to look at inflammation that's not just based on symptoms. Unfortunately, once symptoms develop, either in the postoperative setting or in any patient, oftentimes there's a high rate of surgery. So we would like to prevent that from happening not only in the post-op setting, but in all patients. So how do we manage postoperative Crohn's disease? Should we use 5-ASAs? What about antibiotics, steroids, 6-MP-azathioprine? Obviously, I'll mention and discuss in a minute anti-TNF therapy after surgery, but then how do we follow these patients? I just mentioned that often if we go on clinical symptoms alone, the patients often will feel well after surgery, yet they have a recurrence. Should we do routine colonoscopy? If so, when? Are there non-invasive ways? So is a small bowel ultrasound possibly a modality of the future? Are there other fecal assays or proteomics or other ways that we can measure for early recurrence? So where were we, or where have we been in the treatment of post-op Crohn's? Well, there have been a number of randomized controlled trials looking at different medications. When I initially made this slide set, I have something like 82 slides that follow this slide, and I promise that I'll only show you 3 or 4 of the highlight slides. But there have been a number of studies on 5-aminosalicylates, budesonide, the antibiotics, nitroimidazole antibiotics. So in this country, it's metronidazole flagyl. In Europe, they use a lot of ornitazole, which we have a hard time or we can't get very much in this country. And then 6-mercaptopurine and azathioprine. Some of the slides that I will show you next will emphasize endoscopic endpoints because I think that some of the clinical endpoints in the postoperative setting, now most of us are agreeing that we probably should look at the endoscopic endpoints postoperatively. You probably can't read this slide, but you may be familiar with this study for those especially that do IBD. This was a meta-analysis published on nearly 11 studies looking at aminosalicylates for postoperative recurrence. And if you look at the line on the right-hand side, which is 1, to the left of the line favors 5-ASA, to the right of the line favors control, you will see that most of the studies crossed the line, meaning that there was no benefit of the 5-ASA over control. However, if you scan all the way down to the very bottom and you see that black diamond, which just barely doesn't touch the line, The conclusion from this study are that 5-ASA therapy are beneficial in preventing postoperative Crohn's disease. And certainly in Europe, if you look at the guidelines, 5-ASA treatment is still the primary recommendation in the post-op setting. Well, what's some of the limitations or the problems with this? And if you look at the meta-analysis, again, there were 11 eligible randomized controlled trials that accumulated over 1,200 patients. The definitions of relapse, 7 of the trials used a clinical relapse. 1 looked at radiologic. The 3 that looked at clinical and endoscopic did not show any benefit of 5-ASA, and interestingly, they actually showed a benefit of the control. The number needed to treat was 13, meaning that for every 13 patients treated with 5-ASA, you may have a benefit of 1 patient in a clinical outcome. So I would look at this data a bit skeptically. In my heart of hearts, I think that about 9 to 10%, so it's not 0, 9 to 10% of post-op Crohn's may benefit from 5-ASA. Whether you could argue that's better than nothing at all, it's hard to say. I don't think the 5-ASAs are harmful, but I think we need to look at this data with a bit of a cynical eye when we're looking at 5-ASA treatment post-operatively. Well, what about 6-MP and azathioprine? I think most of us until recently would agree that for post-operative prevention, starting a patient on one of these medicines post-operatively, this probably would represent the most aggressive course of treatment. And this slide may be hard to see, but this is a table that just looks at all of the post-operative 6-MP azathioprine. On the left-hand side are the types of trials. So 3 were randomized controlled trials, 1 was open label, and then at the very bottom was a meta-analysis that was recently done. The drugs, the next column, so it's either 6-MP azathioprine. You could argue that some of the trials underdosed the medicine post-operatively, but nonetheless, all the trials use 6-MP azathioprine. When you look at the results, they're split. 2 of the studies showed positive outcomes, 2 of the studies showed negative outcomes. When you look at the very bottom of the meta-analysis, overall it was listed as a positive study. So to prevent an ileal score of 2, so more than 5 ulcers 1 year after surgery, they found that 6-MP azathioprine was more effective and the number needed to treat was 7. So again, for every 7 patients on 6-MP, 1 patient you would be able to prevent at least an ileal score of 2. However, scan all the way to the bottom for those that can see it, and you see that to prevent the most severe endpoint, an ileal score of 3 or 4, which you could argue probably has the highest risk for surgery, there was no benefit of 6-MP azathioprine over the placebo or control group. So again, we're left with what do we do with this data? These are the meta-analysis slides. Again, you can see for the 4 studies, 6-MP azathioprine, all of them crossed the line of 0, which means that there was no benefit over control. But when we put it together as a meta-analysis, there was a slight favor of 6-MP azathioprine. Still, I would say that 6-MP azathioprine, and not incorrectly, is still probably the most popular medicine post-operatively. Unlike the 9 to 10% benefit with 5-ASA, I do think there's about a 35 to 40% benefit of 6-MP azathioprine post-operatively. So it clearly, I think it's higher than anti-TNF.